that are best for you as opposed to what everybody else is advised. So without further ado, I formed California Age Management as a successor to Longevity, Los Gatos Longevity Institute, which was originally in Los Gatos. We moved to Monterey, and now I'm totally online, which actually for all my patients is much more convenient because as you can see, I'm going to be able to show you graphically and visually um, a lot more information that rather than just sitting across a desk. So here's some initial thoughts and controversies. What does a PSA measure? Originally, Stamey said it really is, a PSA was originally a way of following your course after prostatectomy. And then it gradually became a measure of looking at potential for cancer. What is the correlation coefficient of PSA? It's not as high as you think. What's the value of a biopsy? And a Gleason score. This is where I'm going to challenge you the most. This is where I'm going to become more iconoclastic. What's the value of a digital rectal exam? Every urologist will tell you, oh, I still do it. It really gives me a lot of information. Personally, I think digital rectal exams really, with a good urologist, only tell you the size of the prostate. And even good urologists won't really tell you that. But looking for any kind of abnormalities or signs of a prostate cancer, I don't think it's not the best. What is a Gleason score versus the TNM scoring method? TNM is tumor grade, nodes, metastases. This is probably the area that I'm going to be most controversial because I'll probably disagree with everybody on this point here because every one of you are keyed into your Gleason score.
Yeah.
And I'll tell you why it has less meaning. And this has been my mission ever since the beginning. Ever since I've been talking to this group, I have been de-emphasizing a Gleason score over imaging studies. And imaging studies tell you everything. A Gleason score will tell you what could be. Imaging tells you what is. Statistical jargon, this is what I'm going to spend a lot of time with today, because I want you to be aware of virtually every scientific journal and medical article that you see is confusing. Who should be treated? What is watchful waiting, surveillance? What's the ideal urologist or oncologist? And I can tell you my own journey in terms of what I look for now. And I'll tell you this right off the bat. I have a new rule, kind of my old rule, but I'm really hard and fast about this. And it may be one of the most important things for you. I won't stand for anything less than perfect in terms of all of the people that I see. I'm talking about the receptionist, the scheduler, the technicians, the physician, the center, everything. I won't settle for anything but absolutely the best at this point. At our age, life is too short. So if you have a good doc, but the facility or the people around or the receptionist or the scheduler or the technicians are not really up to snuff, I pass. I've done this with my wife as well. And then what are the ideal treatment centers? And I'll just go through a few that I found along the way. And again, I'll challenge all of you in terms of what you think and what you've heard. So this is where I want to start. Association is not causation. You've probably heard this before, but it cannot be overemphasized. You can have an causation, or you can have an association, but it doesn't mean it's causality. Medicine is not science. Physicians are not scientists. Medicine is really good technology using an art form, and it's failing. The art form is being squeezed out. But good medicine is the use of really high-tech technology, everything that's at our disposal today, with the degree of art. And art is discretion and experience and even intuition. So if you look at causality, at the very bottom is just chance. And there could be a spurious artifact. It could be confounding variables. It could be non-causal. And then at the very top, you can see at the very top of this, there is maybe a causal relationship. A really silly and kind of ridiculous example would be probably every murderer drank milk as a child. I told you this is stupid, but it's true. So you would say, well, if every murderer drank milk, then obviously milk causes homicide. So that's probably the best and the stupidest example, but it gets the point across.
Yeah.
So how far back does this go? It goes back to Aristotle. There's absolutely no doubt in my mind that at the time, maybe even in history, Aristotle was the most brilliant person in history. And clearly at the time, he was the most brilliant person in ancient Greece and in the ancient world. And he talked about causality, and these are kind of sort of archaic nature. So he says the material cause, the formal cause, the efficient cause, and the final cause. And whether we understand exactly what he means, because some of this is actually quite poetic, what he was trying to get at is, again, how do we decide the difference between association and cause? So just recently, I was introduced to this that I guess a lot of people knew about. This was developed in 1965. It's the Hill of the Bradfield Hill. And it's a series of postulates. What is the strength of the association? What is the consistency or reproducibility? What is the specificity of it? What is the temporality in terms of the cause and effect and temporal relationship? What is the biological gradient, the dose response relationships, which I'm really big on dose response curves? What is the plausibility? Does it really make sense? What's the coherence? And the experiment, what can we actually reproduce this over and over again? And can we use analogies? Is this analogous to similar situations? So we have kind of a framework of deciding what is the difference between association and what is cause. I have maintained forever all medicine is politics, and I got to tell you, it's worse today than ever. All medicine and all science is politics.
Mm-hmm.
You know, the best example is Ignaz Semmelweis. For all those who don't know Semmelweis, how many of you have heard of Semmelweis? Good. So Semmelweis was a physician in about 1860, and he had this very simple proposition. It turned out that all of the physicians would go directly from the pathology suite where they had been doing autopsies with no gloves, and they go directly to the bedside and examine women in labor, no gloves, no washing of the hands. And they couldn't figure out why what the incidence of puerperal sepsis, which is childbirth, death at childbirth, was as high as 30%. And that was across the board, 30%. And he had one simple idea: wash your hands. That was it. Wash your hands. And at that time, it was carbolic acid. It said, if you just wash your hands. And in the institutions where he could get them to actually do it, the incidence of puerperal sepsis dropped from 30% down to like 5% or less.
Wow.
But nobody wanted to believe it. And so he was banished. And he went from institution to institution and he was banished. He eventually literally went crazy.
Oh.
And that's an example of how it wasn't time. It wasn't time for people to understand or to accept something new. Then there's Kilmer McCulley, who was the one who decided or tried to show that homocysteine is really toxic. And I've been able to prove over the years, over decades, that homocysteine is really bad for your kidneys. It'll take maybe 15 or 20 years before it shows up. And whether you agree or not agree, RFK is the best example of bad politics in medicine. Hormones do not cause prostate or breast cancer. Testosterone is not the enemy. This has been well proven. And finally, stop waiting for the definitive study. All medicine and science is in progress. The half-life of medical knowledge, it used to be 3 to 5 years. There's some notions now, it's like 72 days. In other words, it's just changing rapidly. And that's why the standard of care is always way behind what the real science and real medicine shows us. What I'm going to spend more time with is the difference between relative and absolute statistics. I've talked about this over and over again, and I'm always waiting to see the little light go off above everybody's head, like, I got it, I got it. And I don't ever think I see it. But I keep hammering people that you've got to understand the difference between relative and absolute statistics. Let's go through this. Here's a correlation coefficient of 100%. No scatter. That means the horizontal and the vertical axis, you can have a straight line. No deviation, no scatter. Virtually nothing has the correlation coefficient of 1. So what if it's 0.7? Look at the scatter just with 0.7. Look at the scatter with 0.3, okay? That is a PSA. PSA correlation coefficient is about 25%. And I talked to Stamey about this at one of the meetings we had. And then I've seen this recently where, once again, correlation coefficient of the PSA and cancer is about 25%. This is the scatter, meaning you could have all the way at the top, you can have all the way at the bottom. When you have scatter like that, you see that line that goes through there? That line is irrelevant. It's irrelevant because there's so much scatter that it doesn't mean anything. Because you could, at any one level of PSA, you could have a high probability or low probability. In reality, PSA measures inflammation. It does not measure cancer. It measures inflammation. It measures BPH. And my postulate over the years that I've never been able to prove because nobody really wants to really study this, I think a good majority of men are suffering from recurrent prostatitis. And it's nascent. It's sort of chronic prostatitis where you got a little nidus of inflammation and it flares up and then it resolves. And it flares up and then it resolves. And it flares up and it goes up and down. And I'm going to show you what that would look like. But I want you to concentrate on that right here. This is the correlation coefficient of the PSA and cancer. So there's another notion that's taken me years to really wrap my head around. And it's difference between sensitivity, which is the ability to detect a true positive, and there's specificity, which is the ability to reject false positives. So sensitivity means you're not going to miss much, but you're probably going to be over detecting. And specificity means you're going to be really right on target, but you're probably going to miss a certain number of cases. So you'll hear this term sensitivity and specificity over and over again. There's this diagram here of a false negative, a true positive, a true negative, and a false positive. And that's what we're looking for, really. We're trying to look for a combination. What is the highest level of a true positive, and it rules out true negatives. So here's one way of looking at relative versus absolute statistics. You can see here, here's 0.5 and 0.1. That's a double. Here's 3 and 6. That's a double. Here's 50 and 100. But if you look at it, you can barely tell the difference here. You can kind of see the difference here, and you really can see the difference here. They're both a double. The better example, I've got two other examples. One of them is if you have 1 in 10 let's say, let me go, I just made this up. If you look at a batting average for the average ball player, which is getting worse and worse than it used to be 40 years ago, the average ball player is about 250. So that means 2 in 10 times he's going to hit. If you have 1 in 1 million to 2 in 1 million, that will be reported as a 100% increase. But the absolute is negligible. So again, what is normal? There's one other slide here that I think it may come up later, but let me kind of emphasize this even further. I want you to get the bottom line here. Relative statistics are always used in medicine and in science to sell you something, to sell you a result. Always. You will almost always see relative statistics used to sell you something. This therapy has this 50% better outcome here, a 25% reduction in this pathology. An even better one to hammer this home is the difference between 4% milk and 1% skim milk is either 25% less or it's 3% less. Relative statistics today in medicine, what we use is hazard ratios, or we use confidence limits. We used to use p-values. All of those are obfuscatory because they're not using absolute statistics. So I want to hammer this home, and I'm doing this over and over again because I want you to get across the point. Everything you will read will be relative statistics. So what is normal? To me, normal is, there is really no normal. To me, what I want to look at is what's healthy, what's acceptable, or what's optimal. Normal just means it fits within 1 or 2 standard deviations of a norm. It goes up to the 95 or 97 percentile, a confidence limit. But it doesn't mean anything. So if you're at the very, very bottom of the normal, you're low. If you're at the very, very top of a normal, you're high. And the way everybody in medicine looks at it is what I call digital medicine, whether you're in the zone or you're out of the zone. Normal is a statistical notion. It's based on a reference population, manufacturer's references. It's a compromise value determined by a committee. So they determine, well, what's normal? Sometimes it's just a consensus valuation by a committee. And this is what I tell my wife. This is what I call the hand on the doorknob syndrome. And I don't know if you've ever experienced it. I'm sure at one time, all of you have experienced this. The doc is sort of halfway out the door with his hand on the doorknob. I don't have much more time, and he's out the door. It's what I call the hand on the doorknob syndrome. And really what it means is, well, I don't have any more time to really discuss this with you. So rather than get into a big, long discussion, you're normal. You're good. See you. Once again, coefficient of variation. There's another way of looking at lab work. If I take the same lab value, the same tube, and I run that tube 10 times, I will get something in the coefficient of variation which has to be less than 10%. You'll have all these values here that are varying. And they're varying because even within the same tube, the same machine, you will get this variation. So kind of piggybacking on what John was just trying to elucidate, everything is about not buying into fear. There's nothing to fear but fear itself. And we could use a little bit more of FDR and less of what we have today. Fear is probably the first thing that you face when someone says you got prostate cancer. And the next best advice that I have for everybody, and I've been telling this to everybody for 30 years, is the most important thing for you is to be a patient advocate for yourself. Get in the driver's seat. Do not be passive. Do not follow exactly what they recommend. It's really hard. I had to go through that myself today. Don't put your life on hold. This guy's 85 years old. I love this slide. So again, Don't buy into fear. Don't be overwhelmed by statistics. I'm trying to show you why. Don't rush into any procedures without thought, consultation, determination, and maybe a second overread or a third overread. And I can tell you that I saw a urologist here in Salinas, and he says it's either my way or it's the highway. I'm a numbers guy. I'm a numbers guy. All he wanted to see was one number. He didn't want to see my blood sugar. He didn't want to see my cholesterol. He didn't want to see my thyroid, my vitamin D. He didn't want to see my hemoglobin A1C. He didn't want to see my hematocrit. He wanted to see one number. And that was it. And so I hit the highway and decided he was not for me. And that was probably the first best decision that I made. Don't be passive. Don't allow yourself to become infantilized by the system. This is what I see over and over again. Those patients who become the best patient, I'm going to listen to everything my doc says. I'll do exactly what you tell me to do. I will not deviate. Those patients don't seem to do as well. And I can give you some really good examples of that. My sister was one of them. So you need to learn to be your own advocate. And being your own advocate, you got to read a lot. You got to listen a lot. You got to listen to lectures like this, successive lectures. And you need to really understand what are the options available to you. Like Kim started out, the options today are way more than they used to be. But let's go through an endocrine primer. Cholesterol is at the basis here. I used to say, you don't want cholesterol is not your enemy because cholesterol is the basis of all your sex hormones.
Right.
And this is the cascade here. And the cascade that's really important is DHEA. Here's estradiol, estriol. These are the estrogens. There's 3 estrogens. There's 1 testosterone. This is what controls your blood pressure. This is what controls your stress. And this is what really balances women, prevents breast cancer and endometrial cancer. No one has ever decided maybe this might be helpful in prostate cancer as well. We all have the same hormones. It really blows me away that the way they approach women with breast cancer is totally different than the way they approach us as men. Women do not have a BSA. Women, when you go to an oncologist, all they do is they say, here's the nomogram, here's our palette, here's our guidelines, follow the guidelines. They rarely even look at the hormones. They don't look at PSA. They don't look at anything. They just say, here it is. With guys, we are subject to numbers, and it's hammered on us. So if you look at, I'm going to simplify it here. So here's DHEA, here's the estrogens, and here's cortisol. Now, this is really controversial. I still maintain this, which is DHEA does not convert to testosterone in men. It converts to testosterone in women, not in men. This is controversial, and I can show you a little bit later on. I think DHEA probably goes down the estrogen pathway in men. It does not convert to testosterone. So you may have heard DHA is really bad for you if you have cancer. And it's very controversial. What's more important to understand is this is what you're looking at, testosterone and estradiol. This, to me, this is what I really emphasize in women, the balance between progesterone and estrogen. This is anti-proliferative. Progesterone is anti-proliferative. And this here is what is thought to be a promoter for breast cancer, but it's not. The question is, would this balance be operative for men as well? And I look at DHA and cortisol. This is a stress balance. And then I look at testosterone and estradiol, which is sexual vigor. And this is what we're all subject to, which is they're trying to destroy our testosterone. And to the extent that we can really substitute for that lack of testosterone, that is the real challenge for all of us, is how can we manage in the face of what they're trying to do is drive our testosterone down to zero. Testosterone is really important for muscle, for brain, for heart, for bone, for sexuality, for stress coping, for all of that. There was a time, I think there was a time, well, there was a time about 40 to 50 years ago, this is even before my time, when they were doing orchiectomies. And orchiectomies were, they literally, orchiectomy is remove the testicles, just cut off your balls, just like a bull. And that was a way of absolutely reducing your testosterone. And also, you're trying to reduce that testosterone down to zero. This is where they come up with the term castrate. And I have a problem with the term castrate. I hate that term. And you'll hear it over and over and over again. Well, men, this is castrate sensitive, this is castrate resistant. I hate the term because it sounds like a Roman eunuch is what it sounds like. And we really need to come up with a better term than castrate levels. What we're trying to do is trying to get to a biological determinant, a biological endpoint. We're trying to get to a minimum, but I hate the word castrate, and you're going to hear that over and over again. So this is really the bugaboo, and this is the one that no urologist or oncologist will focus on. They will not focus on. And I think just because of literature, it's just nobody will pay attention to this, which is I've always maintained testosterone as a pro-hormone. That's not really the goal. The goal is to get this down to zero. The DHT is dihydrotestosterone. And I'll have to tell you, I explain this to every patient, every male patient, and I have to do it every single time that I see them. They say, now, what was that DHT? And the next time I explain it, now, what was that DHT? And again, the next time, tell me again, what was that DHT? DHT is dihydrotestosterone. It is the end metabolite of testosterone. It is 5 times as strong as testosterone. Theoretically, it's the intraprostatic DHT levels. It's the DHT levels that theoretically are driving prostate cancer once you've developed it. DHT doesn't cause prostate cancer, but the theory is once you've developed prostate cancer, what you're trying to drive down is not really testosterone. You're really trying to drive down the DHT. And yet, every nomogram, every doc will tell you that the old drugs that we use, and I'm going to show you these in a second, finasteride and Avodart, that would block testosterone DHT, is not standard therapy. So what I look at is there's 2 pathways here. There's testosterone aromatizes to the estrogens, and I don't want these too high. Although in men, if these go really high, this actually, even though I don't want it too high, on the other hand, there's some evidence that estrogen, even in men, is more important for bone strength than testosterone. The testosterone converts to estrogen in men, and that's what's really responsible for bone tensile strength. So testosterone can convert to either estrogen or it can convert to DHT. That's why really it's the DHT is the endpoint that you're looking for. And I would be willing to bet you that none of your docs are measuring this, because really that's the one that you want to go down even lower than your testosterone. So let's look at this. This is kind of an old diagram. I'm not sure that we're using this any longer. So we're looking at, here's secretory and basal cells. We're looking at, here's a little tumor. Here's a little more tumor. That's a terrible tumor. That's even worse. This is where they'll tell you that it's probably on the verge of escaping the capsule. And one of the reasons why in men, for 95% of us, 95% of us is on a population basis. We'll do fine. 5% of us won't. That's pretty good odds. And the reason is because the capsule here prevents the tumor from spreading. Women don't have that. So you don't have that in the breast, and you definitely don't have that in the brain. In men, we have the capsule, and the capsule is one of the reasons why prostate cancer most of the time does not spread. That's an old way of looking at it. What you've all been subject to is the Gleason score. So the Gleason score is they look at the predominance and then look at the worst case. So the predominance could be 3, and the worst case is a 4. So you're a 3-3, which is a 6. A 3-3-6 is probably what I would call cancer in situ, and you don't do anything about that. You don't do anything. A 7, I maintain you shouldn't do anything about a 7 other than watchful waiting. But this is something every one of you has faced is if you're a 7, what do you do with that? Is it a 3-4 or is it a 4-3? And then there's the worst, which is a 4, which is an 8 or a 9 or a 10. So 8 or 9 or 10 could be a 4-5 or a 5-5. This is what you're all keyed into. Women don't have this. So you got this thing you're all focused on. What's my PSA? What's my PSA? What's my PSA? I started out by telling you the PSA alone is not a good measure of prostate cancer. I think what's more important, and every urologist will disagree with this, every single one. Nobody will agree with me on this. I think the TNM, which come from the Promise Convention, which is another acronym, drives me crazy, is a tumor grade, nodal involvement, and metastases. And the reason why this is important to me is, again, I started out by telling you, you get a Gleason score. The Gleason score tells you what might be, what could be, what usually happens, but it doesn't mean it's going to happen to you. So you don't know. It's all it is. It just gives you some way of postulating a possible outcome. Whereas a TNM, and I'm going to show you how you get to this, the TNM tells you what is today. Where are you today? Gleason score tells you what could be. TNM score tells you where are you today. So how do you determine that? So I just showed you that there was a previous way of looking at it. Now we have this Promise score, and what they have is the T is in various grades here. Here's a T2, a T2B, and they look at here, and they look at here, and they look at here. Okay. Personally, I think I'm a little bit more right about here. But the T score tells you the grade or theoretically the aggressiveness of it. So the Promise score is divided into the tumor grade, and it's then in here. And the M stands for, it's based on PSMA scoring. So it goes one step further, it has a PSMA scoring. Regional nodes, is it in the pelvis? Is it beyond the pelvis? And then distal metastases. Do you have metastases in the bone? Do you have metastases further up? Is it below the diaphragm? Is it above the diaphragm? So the TNM score to me is a far more sophisticated way of looking at where are you today versus a PSA, or a Gleason score, which tells you what might be and what could happen. Gleason score also is population based. It doesn't tell you what's going to happen to you. It tells you what's going to happen to all men in a particular population who had that score, what happened to them. So the classic model is androgens or promoters. And again, this is where I started out a long time ago, and no one's really ever totally explained this, which is why is it the incidence of BPH increases with age, just at the point at which your testosterone is falling like a rock. BPH is rising, and that's also cancer. At the same time, your testosterone is falling. And I've seen some guys with pretty good levels. My levels are pretty good. But as a rule, you can see this is the average. Your levels are falling just about the point at which you're developing either BPH, prostate cancer, chronic prostatitis. There's also a general rule. I don't know how accurate this is. And again, nobody's really figured out why is this, that maybe give or take as an approximation, you have about a 60% chance of developing prostate cancer at 60, 70% chance at 70, and an 80% chance at 80. Maybe it's not that high, but it certainly increases with age. The prostate cancer is the most commonly diagnosed cancer in men, despite the high morbidity and mortality, which is not high, its etiology remains obscure. I've been using this slide for the last 25 years. It doesn't really change. I still don't think anybody knows what causes this. Why do we develop this? Why are we subject to this? Why? Why do we have to go through this? Although compelling lab evidence suggests a role for androgens, most epidemiologic data suggest in humans are inconclusive. In other words, testosterone does not cause prostate cancer. Androgens are major growth factors. Prostate cancers retain the androgen receptor. And I'm going to show you why the androgen receptor, and this is my theory, and I'm going to show you why this was the predominant theory. It's changed, but I even talked to my oncologist today, and he didn't disagree with me on this, which is essentially after a period of time with androgen deprivation therapy, with these drugs, injections, anything that you're taking, eventually we all become resistant to these drugs. Why? When? How? My theory is that, again, DHT here is the most important one that they're not measuring. So let me show you this, and I'll come back to answering that question. This is another one that every urologist will disagree with this. Every single one. They all disagree with this. It took 18,000 men with a normal digital rectal exam, PSA less than 3. Gave them finasteride, Proscar, 5 milligrams for 7 years. This is just prophylactically. Let's see, did this prevent prostate cancer? And it turns out 18% of those men after 7 years, and this is a good study because it was 7 years, developed prostate cancer. However, 24% of them, and only 20, well, here, 18% developed cancer, 24%, 24% developed prostate cancer in the placebo group. In other words, those who were treated only had an 18% incidence. Those who were not treated had a 24% incidence. So it looks like, wow, the finasteride really did help. Less incidence, right? However, turns out there was a higher percentage of higher grade tumors in those men who were prophylactically treated with finasteride for 7 years. They had higher scores, 7, 8, 9, or 10.
I never took it.
So every urologist said, no, this is BS. This is not true. Okay. And when you can see right here, the lower grades here, you can see the blue line is placebo, meaning that in those who were treated, the red line here, they were less until you got to that grade 7. And then the Proscar, those who were treated actually had a higher incidence. Pretty convincing. So all the urologists said, no, it's not true. Well, what they did was they said, okay, let's do it again. Let's do it with Avodart, which is a different 5-alpha reductase drug. Got the same result. Same result. Those who were treated with Avodart, here are the lower grades, but in the higher grades, they higher incidence of prostate cancer. So if you look at, so my theory is, and I'm going to get to it 1 or 2 slides from now, is that what we're doing in the end is the problem is we're mucking around with the androgen receptor. So if you look at the 5 androgen, this is one way of looking at prostate cancer, and this is not standard of care. So standard of care is not to use one of these drugs to treat prostate cancer. Even though I just told you DHT is the strongest hormone, is the one that probably has the greatest effect on the prostate. Nobody's looking at that as an endpoint, and they're not treating the conversion of testosterone to DHT. So if you look at this here, and I'm going to go over this quickly, you can see the impact of ADT on sensitive cancer. We look at DHT levels. Here, blocking this would enhance it. Um, suppressing ligand-dependent cells, often beneficial in the short term to midterm. I'm going to come back to this in a bit. There's a lot of information here. So let's look at this. Let's look at the genetics, because I don't know if any of you have had germline testing or somatic line testing to look at different reasons why you might have developed prostate cancer, looking at BRCA, looking at Lynch syndrome, and a couple of others, P53. It's the androgen receptor signaling that is the problem. This is gain of function. So my theory has been, and I can show you, these were the earlier studies showing when you deprive the prostate of testosterone, it's the androgen receptor is upregulating because it's being deprived of testosterone. So in order to do its job, it's upregulating. It's gain of function, kind of like COVID. All those that mRNA is gain of function studies.
How to do
How do
it?
you amplify it?
I don't either.
So this here is the androgen receptor. It's pretty complicated. We look at androgen receptor and how it's affected here. You can see here's DHEA that I told you about. Here's testosterone.
What happened? Let's see
Out here. But this is here. Look at this. Here's DHT as the endpoint. Okay. Here. So although individual cases have been reported of anabolic steroid uses, epidemiologic studies have failed to establish a link between elevated testosterone, DHT, and prostate cancer. I've kind of emphasized this over and over again. This is where we come into what I said. I don't think DHA is a problem, but you can say, well, there's what we call paracrine and autocrine. There's other forms of endocrinology where DHEA may affect this, but this still really isn't well known. But it's been studied, but nobody will really focus in on this. So there's never been any really adverse consequences of DHEA, no meaningful associations. Here's the genetics that I talked to you about. So if you've had the genetics done, which you should all probably have germline genetics done, you look at breaks, deletions. This is
I
what
got it now.
This is. I'm going to mute someone here. Mutations of the AR gene, that's what I've tried to sort of lead you into, is that I think it's up-regulating gain of function mutations of the AR gene, that's the androgen receptor. And I think that's the reason why all these drugs eventually fail, because of gain of function. There's oxidative stress. This is where I think vitamin E and oxidation antioxidants come into play. This is the one that I focused on forever, which is suppressor genes. And again, germline testing will tell you what's the vigor of your P53. That's a tumor suppressor gene. That's the most important one. But in prostate cancer, and apparently we can't measure this commercially, P27 is the one that's really most important for suppressing prostate cancer. And P16 is one that's regularly looked at. So P16, P27, and P53 are tumor suppressor genes. The maybe good news is, to the extent that we can make this assertion, vitamin D is supposed to enhance the integrity of tumor suppressor genes. And that's the reason why I take really high dose vitamin D. I take 15,000 units a day.
Wow.
Cancer will downregulate the suppressor genes. This is what I'm talking about, the genetics. We look at Lynch syndrome. Lynch syndrome used to be colon cancer, endometrial cancer, and maybe ovarian cancer. But now they're beginning to think, well, maybe it affects prostate cancer. So this is a genetic variant that can be treated. BRCA genes. We used to think that BRCA genes were the things that really are of only importance to women. If a woman has a BRCA1, BRCA2, they've all been frightened to death that they need to have bilateral mastectomy right away. But this is also apparently becoming more recognized as a genetic defect in men. This is another one. These are the tumor suppressor genes that I just mentioned. You have probably all had a decipher score, and I'll tell you why I bypassed this. Um, how many of you had a decipher score? Probably at least two of you, all of you. Family history is of some concern, but genetics tells me maybe not. And this is what I was alluding to, like having germline testing and then somatic testing. My oncologist today told me somatic testing really is of more value once it's determined that you're developing um, androgen resistance. Your meds are not working. So multiple genetic changes that are necessary. They're molecular abnormalities. And the molecular changes are in these various luminal cells in the prostate. Again, androgen receptor, androgen function as a growth suppressor by its ability to inhibit andromedan. This one here, let me skip over that. Um, these are what I used to look at. I don't look at these as much anymore. So these are some of the earlier ways of looking at genetic abnormalities. And we looked at these here. The one I think that is still in use, though, is P10. So if you've had prostate biopsy, if they're really good, they'll look at your P10. They won't look at any of these others here, but they'll look at P10, and I'll show you why. So what happens is you have this progression, and it's a progression here from normal to barely something to maybe a little bit of prostate in situ to metastatic to androgen insensitive. So you have this progression here. And here, theoretically, you have telomere shortening, and telomeres are supposed to protect you against cancer. Also, very controversial, but I think this is true. As our telomeres, which are the end caps of our DNA, as they shorten, you are more likely to develop cancer because of inability to repair, telomerase activation. So again, this is a progression from normal to prostate cancer. Here's that P27, here's the P10, shows you once again, even when I look at this, I have to look at it over and over again. And the only reason I'm showing this to you, even though it looks complicated, is to show it there is no one pathway that says, here's the pathway that we need to target. It's never that simple in biochemistry. It always gets more complicated. You see it's more complicated here. Again, re-emphasizing that prolonged use of ADT will induce gene mutations in the androgen receptor, leads to a rise in PSA, and I think that's probably what causes androgen insensitivity, what they call castrate resistant. So the clinical workup, and I'm pretty close to the end here, so I think I'm on time, is I want you to have a PSA. Told you what the problem with PSA is. You want to have a hematocrit. Hematocrit, are you anemic? Fibrinogen. Everybody needs a fibrinogen. Fibrinogen measures thickness of your blood, tendency to clot, also an acute phase reactant, which shows inflammation. But you also want to know high fibrinogen levels is a risk for heart attack and stroke. You want to look for alkaline phosphatase, PTH, calcium. Again, I even talked to my oncologist today. He kind of said, well, we don't look at this. I think alkaline phosphatase is a surrogate for, is there anything going on in your bones? And again, nobody else is looking at this. I don't like to see rising alkaline phosphatase levels. The only time I see a really rising alkaline phosphatase levels that is normal and physiologic is in a 14-year-old male where he's growing like crazy in the summer. Then you'll see these things shoot up because of bone growth. You need to have a lipid profile. Hormonal profile needs LH, FSH, testosterone levels, and that should be free, total, and DHT, maybe bioavailable. And when you're doing these, you should always ask for a high sensitivity testosterone level. You want an LA, you want an LH, you want a, I'm blocking it right now. Hold on a second here. With testosterone, you want really high sensitivity testosterone. You want a GC-MS-MS level of testosterone. You don't want a normal one. You want a really high sensitivity testosterone level. Same thing with the PSA. You want high sensitivity PSA. It should always be high sensitivity PSA and a high sensitivity testosterone. I have the advantage that you don't have. I can order my own labs.
Right.
So I go way beyond what my urologist or endocrinologist or my oncologist would recommend. So I have the ability to measure all of this because they don't measure all this. They're not interested. They're all interested in the PSA and the total testosterone. You want to look at your thyroid. Thyroid's critical. Thyroid is the seat of immunity. Thyroid is the seat of immunity. The other seat of immunity is your thymus gland. And thymus gland is the seat of all your T cells. And as we get older, our thymus gland involutes and gets smaller and smaller. So your immune response gets weaker and weaker as we get older. So thyroid is one measure, and you really want your thyroid to be high. You want it to be vigorous. So I treat myself with high doses of thyroid. Really, really good endocrinologist who lives in Belgium has shown a graph. I've been trying to find this graph of women with thyroid and breast cancer, and he showed that the more active the thyroid, the better women did, and the lower the incidence of breast cancer. I'm sure it's the same thing with prostate cancer. You want a DPD for calcium bone loss. A DPD is way of looking at, again, you're looking at calcium and calcium that's coming out of the bones. Calcium that's coming out of the bones is going into your heart and into your blood vessels. Calcium should be in your bones, not in your heart, in your valves, not in your blood vessels. So you want to look at a DPD for calcium bone loss, and you want vitamin D levels. And I get constant vitamin D levels all the time. I don't do when. Virtually every study, and I will have some disagreement here. Every study of vitamin D levels just measures at the beginning or at the end. Further lab testing, you want an LH and FSH. That's what you're dealing with when you're doing Lupron, or as one of you mentioned, and I never could pronounce it, so I use Orgovix. Orgovix is Relovix. I can never pronounce that. You want to look at free and total testosterone, again, the LCMS version, which is the high sensitivity. You want to look at DHT. You want to look at, now these are some things that Stephen Strum has given me. No other oncologist will talk about these, but these are more advanced biomarkers of your state of your prostate cancer and things that we can target. Nobody else will look at the prostate acid phosphatase. Nobody will look at chromogranin. Nobody will look at neurospecific enolase. None of them really look at DHT. None of them look at prolactin, which may be another promoter. And then finally, getting toward the end here of this one, this is what I've been talking to the group about forever. I am not an advocate of prostate biopsies. And I'm the only one here who's not had a prostate biopsy. And I've refused it because I've been a real strong advocate of MRIs. Originally, we were doing endorectal MRIs, and I was sending people down south. A lot of the original studies were done at UC San Francisco. Now we just have abdominal MRIs. The urologists are finally in the last 5 to 8 years are beginning to say, okay, we're going to get the abdominal MRI. But they really have been very resistant to doing even MRIs because the biopsy was it. But the MRI tells you much more information. MRI will tell you have a tumor. Is it involving the neurovascular bundle? Is it involving the seminiferous vesicles? Is it involving your lymph nodes? Is it involving any other organ? It gives you so much more information. Now what we have is we have PET CT scans. So total body PET CT scans, which goes further than the abdominal MRI. And the latest is, and I've actually probably been one of the first sort of unwittingly to do the PSMA scans. And now, luckily, this is becoming more and more accepted where to me, this is standard of care. And any urologist who says, I'm not going to do a PSMA scan, it to me is, it's a pass. And
Yep.
that's where I parted ways with my local urologist here in Salinas. PSMA scan is the standard of care today because the PSMA scan stands for prostate specific membrane antigen. It's the one that's specific for prostate cancer, whereas the PET CT scan is not specific for prostate cancer. The DEXA scan, you should all have that for your bone density. Stephen Strum has really argued for the quantitative CT, that's QCT scan, which is a little better. I went to UC San Francisco to have this done. It gave me a little bit more information. It's supposed to be better, but it's a different way of looking at it than the DEXA scan. And I'm really big on this. Luckily I had a baseline cardiac exam by a good buddy of mine who's a really good urologist here locally. And I had a baseline EKG, which showed a few little abnormalities. So he said, let's do a Lexi scan. Lexi scan is a way we can look at, it's like a stress thallium test. So now they're using Lexi scan as opposed to stress thallium. So you really need to have an echo and a Lexi scan for a baseline cardiovascular because the two target organs that you're suffering the most with androgen deprivation therapy is going to be your heart and your bones. And if you're not lucky, it's going to be your brain and your muscles and your balance and your overall happiness and your energy levels. Not to mention maybe hot flashes and night sweats, resting EKG. This was something that was really big. I never could get anybody to do this. They said Shinohara in San Francisco does this. I don't think he does it. There was a Duke Bond down in Orange County was doing it. I don't know if he's doing this any longer. I don't know why urologists have never adopted this. A colored Doppler ultrasound is a way of doing an ultrasound of your prostate, where they can do this every month. It's non-ionizing, but the color Doppler means it's showing metabolic activity. And they're not even doing this on breast exams. They should be doing this on women too. Color Doppler, because I had trouble even getting ultrasounds on women as opposed to just straight mammograms. So color Doppler would be the best way, but we've gone to abdominal MRI, followed by a PET CT scan, followed by PSMA. This is what you need. That's the standard of care as far as I'm concerned. And you should have a baseline bone density and a baseline heart workup. Digital rectal exam, I think it has limited value. Looking for lymph nodes, and I am going to conclude it right here and leave you hanging in terms of why prostate biopsy, why not prostate biopsy. I'll give you a little hint though. Just go on YouTube and Google biopsy, no biopsy, and you will see there is a wealth of information on this. It's not just me. You can see there's a wealth of information. So let's go through here. So this is Stephen Strum's book. Stephen has been really, really kind to me, both in terms of patients that I've dealt with in the past and personally to me in terms of giving me my own guidance. Stephen Strum is probably the top integrative prostate oncologist in the country. He was doing a lot of writing for Life Extension Foundation. He's got a lot of books, and it's even worth talking to him. He's opinionated, but he's really very good and has so much experience. This one here, this one here. Look at this one here. Look at this one here. And then finally, you got to read this one. This is my book. published in 2005. Still probably one of the best books in anti-aging medicine and longevity medicine on the market. Virtually everything on here is still operative. I would probably add to this a little bit in a second edition, but still well worth your read. Remember, this is where we came from. This is what we're trying to avoid. This is my hero. I was so lucky to have talked to him a few years before he died. And he said, I hate talking to old people. I like talking to young people because they're much more enthusiastic and they listen to what I say. And he gave me a whole series of his glossies, and it was amazing. He looked the most buff, the most healthy when he was 47. And when he was 85, he still looked, this is, I think, of when he was 84. So this is what we all aspire to, is living a healthier life and living beyond what they tell us we can live beyond, and enjoying our grandkids, and if you're lucky, maybe even your great grandkids. And with that, I will turn this back to John. And does this turn this back to you, John?
No, you got
I have to do.
hover over my name and then hit the 3 buttons.
All right. Okay. Your name here and. Oh. Yeah, here it is. Okay. There we go.
Oh, yeah.
Okay.
Thank you. That was great.
Thank you.
Now, how can we get, I took notes, but I couldn't keep up with, I couldn't take notes fast enough. How can we get
Try to
those,
talk slow.
get
Slower than I
those
usually
charts?
talk.
Are the charts in your book?
No. No, none of this is in my book.
Well, that's what I want. I want those lists of I want to take them to my urologist and say, these are the tests I want. I'll just give you one example. I asked for a DHT test at Kaiser to my urologist or to my prostate doctor, and she said, well, I wouldn't know how to interpret it.
There
And
you
I
go.
said, I don't care. I just want the score. I'll get it interpreted.
Okay. So you have two alternatives here. What I can do is I can give you that list of the tests there. That's easy.
Yeah.
I can give that to you. I could put that back up. Depends on what our time is. But you have a couple of alternatives. One, if you go to Kaiser,
Well, I'm not there anymore.
be limited. Okay. What you do is you have a couple of alternatives. One of them is you can use Life Extension Foundation where you don't need any doc. You can order those.
Yeah.
The other one is I have the ability with all my patients, if they have Kaiser or they don't have insurance or something like that, I go through FullScript, which is my online pharmacy. And through FullScript, I can order tests that are actually will compete with Life Extension. I mean, I can order a complete test, total,
Yeah.
all the things that I showed you for give or take about $350. And you won't have to have any codes. It won't be denied. It won't go through Medicare. It's just you just pay cash and you get everything you want. And it'll have the DHT and the testosterone and everything. So you have two alternatives. You do Life Extension, you go through FullScript. Or you just have to negotiate with your doctor and say, hey, I want to do these. And if they tell you, I don't know how to interpret that, then you need a new doc.
Well, that's what I did. I'm not in Kaiser anymore, but
Philip, how would we get in contact with you?
Well, I had it on the back here. So you can get in contact with me at Dr. Miller at antiaging.org. That's Dr. Miller at antiaging.org. O-R-G.
and Ken and
And if
I,
for some reason you forget that, you can go through Ken or you go through John. They can get you in touch with me.
I think the presentation is being recorded. We'll try to get that up
Oh, I
online,
gotta be
if that's
careful what
okay
I
with
said.
Philip. To me, it's all about the interpretation of these numbers that you refer to, and what do they really mean? And that's the way you opened up your presentation. I know Stephen Strum personally. I haven't talked to him for a long time. Uh, he is just such a stickler on testing, and I know you're big on testing too. But for an awful lot of us, these tests aren't real affordable.
I have not had any problems with that. I use Medicare. Maybe they're waiting, but I've seen no kickback from Medicare.
Yeah.
Well, do you use Medicare? Uh, if I come to you, can we use Medicare and Blue Cross?
Uh, you can use for the lab, but not for my services.
Yeah.
I'm just
Well,
mentioning for, because I don't know, I might be older than any of you. Um, I've used LabCorp, and a lot of it is, I mean, I've been fighting this my whole life. You got to have the right codes. And it just gets more and more. You got to have this code. No, now you got to have 5 codes. Now you got to have 10 codes. You got to have a code for everything. And if you learn the game and how to code it, all of these tests have been paid for.
how true it is. And
There's
you,
also another thing too that every doc, I've heard this before. I'm pretty sure this is true. Every doc has a profile. So if your profile is like little bit and suddenly you order a lot, kind of a red flag. But if you're always ordering a lot, there's no red flag there, and it seems to be easier. So some of it is the way the doc orders it, because the way the system is going today is just do 4 tests, just do 5 tests, because if we do more, then they're not going to approve it, and you're going to have a kickback, and so why do it? And so they just give up. They just give up. They just say, I don't want to fight the system, so I'll just do about 4 or 5 tests. But forever, we do complete profiles in everybody, every single time people come to see me.
Philip, a little plug for Life Extension Foundation. And I've mentioned it every year to the guy. I think their sale is off, but they have a men's panel. They have so many different tests, as you well know. But to me, the real value of life extension is once you get your tests back, you can call an 800 number and talk to a physician that can, and you can talk to them about it. You can ask them about every one of those tests, whether they were
Mhm.
supposedly normal or abnormal.
Mhm.
And that's a great value because as we know, he's got his hand on the door, right?
That's right. And in the doorknob syndrome.
Yeah. And it's gotten a lot worse, as you well know, and the politics of medicine and the marketing in medicine has gotten so blatantly in our faces. Uh, we have to be more discerning all along, and that's why we advocate the PAF mantra is you got to really take care of yourself so you don't get in those positions that uh, so many guys don't understand the language. You just feel so vulnerable and at a loss, no matter what the disease is. But most guys don't even know the right questions to ask.
That's what I've tried to emphasize, throughout this last hour is be your own advocate, be in the driver's seat, don't be passive. And I'll tell you, my number one rule right now is don't settle for anything other than the best. And I mean the best. The facility, the docs, the receptionists, everybody in the facility. If they're not the best, pass. It's not worth it. Life's too short. I just did this with my wife. She was scheduled for shoulder surgery. And I liked the doc, but the system it's a local system and it just wasn't responsive. I said, this isn't working. Found an orthopedist who's really well known. The receptionist called me back. They texted me. They contacted me 3 times today after I called them. That's what I'm looking for.
You bet. You bet. Well, you know, Dr. Miller, I was fortunate. Dr. Bond taught my doctor, who's a naturopathic doctor, Tambury in Phoenix, Arizona, and I've had 11 of the color Dopplers. And of course, then COVID hit, and it kind of killed me going there. But I was very impressed with color Doppler. It was very good.
So you went to Bonn?
Well, no, Dr. Tambori, Dr. Frank Tambori is in Phoenix. He's
Yeah.
a naturopathic urologist there.
Yeah.
He was taught by Dr. Bond.
Yeah. Because I think Bonn was the only one doing it.
Yeah,
So
he
maybe
was,
he
and
taught
then
her then.
he
Okay.
taught
And wasn't
Frank.
Shinohara doing color Doppler
Yeah,
ultrasounds?
Shinohara does it.
Yeah,
Yeah.
that's what I've been taught, but I don't know anybody who's actually gone to him and had it done. So
I
I
think
heard he
I have.
does it.
I have.
Okay.
I
have-
have too.
I
Okay.
have too.
From
We've
Shinohara.
already, the PAF has always advocated those two doctors.
Okay. The only thing is that Shinohara, he's got his needle ready. That's his thing. So he may
Well,
do the
he's
color
not-
Doppler, but it says, okay, now I've done it. Now let's do the biopsy.
Shinohara does not have a bedside manner.
No.
So I went to Shinohara for the testing, but Shinohara talked to my radiologist about what to do.
Yeah.
For me. So
Next time I'm going to talk to you about facilities that I recommend.
Yeah, well, that's be a good talk.
I'm going to leave
So
that.
just point of information, I'm almost 100% sure that Dr. Duke Bond is retired now.
Oh, I'm sure he is.
Yeah.
Yeah, I'm sure.
Dr. Bond? Oh, yes.
Everybody's retired. I'm the only
Yeah.
one not retired.
I've gone to both of them specifically for color Dopplers, just like
Yeah.
Bohan. Dr. Shinohara, as good as he is with his diagnostic skills, I would always, when I would set up an appointment to see Shinohara for the biopsy, I would at the same time schedule an appointment with my urologist, Peter Carroll, 2 weeks
Yeah.
later. So I'd make sure he got that information from Shinohara and so that he could interpret it for me rather than have Shinohara. One of the mistakes a lot of guys make, and I'll use Shinohara as an example. He's world famous for his diagnostic skills, but he does a lot of other stuff too. Maybe as well, maybe not as well. He treats BPH with what's that one? Resume. He does radiology, and he does he uses all the other tools. But, I like to think personally that I have a team of doctors. People always ask me who my doctor is. Well, I use this guy for one thing. I do, I mean,
Yeah.
and I talk to so many guys that they say, okay, I like the story that you've given, Ken, in terms of taking a proactive approach, but I've already scheduled my radiation or whatever it is. And I don't know how to tell my doctor now that I don't
Yeah.
want to do it. And do you have any suggestions there?
It's difficult.
It is difficult because
Difficult.
most guys like their doctors because they got a good smile or they both like the University of Michigan football team or whatever reasons may be. And very few of those reasons are really what their credentials and skill level are in most cases, because most guys don't know how to even do the research to find out. Most of it's a referral.
Nobody
Well-
likes confrontation.
Yeah. I can
Mark,
tell you,
what kind of radiation were you looking for? Doing? Or Ken, Ken,
Say that again.
Ken, what type of radiation were you looking at doing?
Was I looking at personally?
Yes.
I wasn't looking at any radiation.
Oh, okay. I thought I meant
No,
misinterpreted.
no. I mean, I had 25 years to make my decision, a lot
Right.
longer than most guys.
Yeah, no, that's right.
And I learned when I was in orthopedic medicine, helping orthopedists learn better how to do the hip and knee replacement surgeries. I watched surgery almost every day, and I used to tell guys of the 1,000 surgeons I've watched do a knee replacement, I can count on one hand the ones that I would personally go to.
Yeah,
Uh,
it's true.
it's gotten a lot better than that because, that's just become the most popular procedure in America. But
Right.
uh, my idea when I was diagnosed in 95 is could I find something proactively that I could do to stall the growth of my prostate cancer while I got better at it with less side effects and more consistent results. And what came out the other end is a prostate-friendly diet, as much
Absolutely.
exercise as you could safely tolerate, a good and regular stress management program, and really a zest for life and wanting to stay alive and really staying on top of things and using
Right.
your brain.
Little exercise goes a long ways.
Well, we
Whatever
know
you
that for
do,
sure now, but we didn't 30 years ago.
No, I know. Well, 30 years ago, you were in great shape. So was I.
Yeah.
At 84, it's a little different.
Yeah. And I'm right behind you, Gene.
Yeah,
I'm not feeling as
amazing.
spry and youthful as I used to, but I think it's important to emphasize to guys that 97% of guys with prostate cancer don't die from it. Usually hear it the other way around. Only 3% of guys die from prostate cancer. But
Right,
to me, that 97% is much more profound when you say it that way.
right.
And it's all in the presentation. And I'm digressing now, but I remember reading this study out of Memorial Sloan Kettering. And the urology team there was really frustrated because they felt like 60% of guys that went ahead and had radiation or surgery could have really done an active surveillance, watchful waiting sort of a protocol. And they couldn't figure out why that wasn't being utilized more. And what they realized with work with Stanford Business College was it was the way urologists presents options. And just about every urologist 10 years ago, they would first mention surgery, secondly, mention radiation, thirdly, recommend the hormonal blockade. And then it was, oh, by the way, there's this thing called active surveillance. So most guys were taking the first two choices because they were presented first. So Harvard and Stanford business schools, they recommended that at Sloan Kettering, why don't you recommend the active surveillance first? And when they started doing that, the numbers just changed totally. It went from 60% of guys that could have done it that only 20% did. It went to 60% of the guys were doing it. 70% of the guys were doing it. So it takes a while for the boat to change course, but it's happening. And now there's no need for a biopsy. That's pretty profound, isn't it?
That sure is.
The number
It's
one
the truth.
question, the number one concern of guys that call the PSA over the Prostate Awareness Foundation over the last 30 years is, I don't want to have a biopsy. I'm afraid of needle tracking and its spread. I'm afraid of infection, both of which are much higher than the published literature acknowledges.
Yep.
And so my general answer had been all the way up till tonight, I guess, in terms of hearing from Phil Miller here. I used to refer to that. If you're 84 years old, Gene, you got an 84% chance of prostate cancer.
Oh, yeah.
And they found the other extreme. They looked at guys, they autopsied guys in Detroit. Uh, Guys mostly were dying from gunshot wounds. And
Yeah.
guys that were 28 years old, you know what? They had a 28% incidence of prostate cancer already.
Hmm.
And I was shocked when I got my prostate cancer diagnosis for my 50th birthday present. Well, I learned that I had a 50% chance of having it then even, you know?
Yeah. Well, it takes about 25 years for it to actually show up sometimes.
That's what they say, and I suspect that's probably an average. That's maybe the
Right.
normal, as Phil pointed out. What is really normal? What I learned a long, long time ago, about 2 years into the Prostate Awareness Foundation, was that there were a lot of guys that had PSAs over 10. And it used to be in 95, if you had a PSO, if you had a double digit PSA, you better go and get treatment right away, Ken. You know,
Yeah.
don't mess around. And I was talking to lots of guys with PSAs that were really high that didn't seem to be progressing much. And correspondingly, I was talking to just as many guys that had PSAs over four, under four, uh, that had rapidly growing prostate cancers and were dying from it. And that's when I really realized that there was really not much of a correlation between PSA and diagnostics anyway.
Yeah, you can have zero PSA and still have cancer. So
So one book that Philip didn't mention that I think is really profound is called The Great Prostate Hoax. It's written by Philip Albin, who's a PhD that was the first one that isolated the PSA molecule way back in the 70s. And his first chapter is devoted to an apology to all men that went ahead and had treatment because of their PSA numbers. He said it was never meant to be that. It was meant to be a marker after you get after you get diagnosed. That's really when it has value. Which way is it going, and how fast is it going there?
yeah, I've always done a PAP, a PSA, and a PSA complex for 16 years.
I know you have, Gene. Yeah, and
Yeah.
Phil said
I
that.
only had one biopsy. That was the last one. I learned my lesson.
Ken,
Yes,
can I ask a question of Dr. Miller?
sure. Yeah, that's what we're here for.
He mentioned the rapidity with which science is changing, advancing over the last few years. And I'm curious, is there any experts that would be dealing with the lutetium 177
Right.
and as a first treatment rather than as a last treatment, especially a direct insertion into the prostate rather than intravenous, which seems to have a bad effect on the saliva glands?
It's a great question. And I think there's a couple of reasons why that's not happening yet. One is the drug is absurdly priced, ridiculously priced. It's criminal. That drug is like $100,000.
A treatment.
So, well, it's $40,000 a treatment.
Yeah.
So it's absurdly priced. So that's one thing. I said, okay, so we're going to have to develop an algorithm for this because we can't do it for everybody. And then partly because of that, you said, well, you have to meet these prerequisites. You have to have had a biopsy, then you have to have resistant prostate disease, so you become resistant to ADT. Then you're ready for Pluvicto. But I don't think even at the major centers they have enough experience with Pluvicto to know, can we do it earlier? And I think it's going to take 5 or 10 years before I say, oh, actually, we found out we could do it earlier. Or, what are the side effects from it? So it's so new, it's so expensive. There's a lot of unknowns. I think theoretically makes a lot of sense to me because it's sort of, it's Ehrlich's magic bullet. It goes specifically to the prostate cells. So
The question
there's
I
a
would
number of
have,
reasons why you won't see it, but that'll change in the next 5 years.
the question I would ask is if it was direct insertion into the prostate,
Mhm.
the way some other things are done, it
Mhm.
would require less than 2%
Mhm.
of the dose put into your veins. Because your veins has got to go throughout your whole body, and you're talking about a 50 gram prostate.
Yeah.
So why wouldn't the price be less than 10% of the 40,000 you mentioned? In which case it would be perfectly reasonable and it would avoid the major defect is the saliva gland problem. So I just cannot understand why they would not do this, other than the fact that it would disrupt the profit from surgery and radiation.
That's why.
It's the expense. See, the question is, and again, I'll talk about this more next month. How is it better than cesium seeds? And I don't know, they'd have to do some sort of RCT comparing the two, which is never going to happen. But you have to compare how is it cesium seeds versus Pluvicto, which would be better?
Thank you.
Doctor, have you ever heard of the BAT, the bipolar androgen therapy?
Mhm. Yeah, that's what I want.
Okay, well, I've been researching that along with the
Yeah.
LUF 177, and I tell you what, I really like the BAT. I'm 84 years old. I've got a 63 to 635 testosterone. And the last thing I want to do is to kill my testosterone. So by lowering my testosterone and raising it, lowering it, raising it over a matter of weeks, they eventually feel that the testosterone will actually help fight the cancer.
Well, there's a really notable physician who's at Harvard, Abraham Morgentaler, and he's really big on treating prostate cancer with testosterone. The thing is, I've never figured out how does he select those people, because his idea is saturation kinetics and at a
Right.
certain point. So the theory, and it was just explained to me today, this is kind of the thinking, is that when you develop those resistant cells, somehow testosterone now treats it, whereas it didn't treat it before. I just think it's an unknown. It's a real unknown because it's like, well, that's counterintuitive. But I think that BAT or IDT, whatever you call it, I think it's a great idea. The only question is, how do you select those patients? At what time do you do it? Because we all want that as our therapy.
Yeah, that makes more sense. I know John Hopkins, I read a whole bunch of articles from there that they've been testing it for many years.
Yeah, look up.
They're offering it.
He's the one who's a real big one. He's the biggest advocate of high dose testosterone and prostate
Right.
cancer.
When you mentioned Dr. Morgenthaler, I wanted to show this book. I don't know if you can see me, John.
You're kind of in the dark, Ken.
Yeah, you're in the
not
dark,
very
Ken.
well. You're sort of backlit, Ken. I can't see you.
This book is called The Truth About Men and Sex, Intimate Secrets from the Doctor's Office by Abraham Morgenthaler, MD.
There you go.
It's a terrific book.
Yeah, there you go.
Yeah, he tells the truth about it.
Yeah, he's a great speaker.
Testosterone, yeah.
But I will have to admit one thing, and we're all different, okay? I will
Yes.
have to admit they got my testosterone ridiculous. I don't like it. It's down to 30.
Yeah.
My DHT is down to 10. So that was after 2 weeks of therapy. I mean, I've hit their targets, okay?
Yeah.
And my brain still works.
Yeah.
I can still walk. I hike 4 to 6 miles twice a week. I lift weights. I take a huge amount of supplements. So
Good for
I've
you.
been surprised, but it's partly because of the drugs I'm on, that it hasn't wrecked me. That's my
Right.
main concern. I'm not where I want to be, but it hasn't wrecked me. So that these things are tolerated better than I thought. And that seems to be the current wisdom. If you're like 40, these will destroy you. If you're 50, they'll wreck you. When you're about 70 or 80, yeah, they don't
Yeah, when
affect
you're
you.
80, you aren't going to get destroyed no more.
Yeah, right. Somehow we tolerate it.
Yeah, right. That's about the last thing we think about.
So, Philip, you're going to meet with us again next month, and that'll be November. Let me check the date here.
I'll talk about therapies and more approaches and talk about who the docs I recommend and the centers that I recommend. I wanted to give you this foundation of how do you approach being an advocate and how do you look at statistics. I can't overemphasize this enough. So that's what I wanted to do. Today's sort of introduction, a reintroduction to what I've been doing for the last 25 years with you, Ken. And then next month, we'll talk about some really interesting
So
follow-on.
that meeting will be November 17th.
Okay.
And we're going to sign off now. We really
Okay.
appreciate you being here, Phil. I know you're one of the boys, so you feel a little bit differently now, but welcome.
Yeah.
Okay.
Yeah.
You're welcome
Okay.
aboard.
Yeah.
John,
Thanks.
did you have anything else to say?
Well, I'm looking forward to next month. And also, I would like to get together with you down here in Monterey, maybe go out to lunch or something.
Okay, John, that'd be good.
Okay, I'll call you.
Yeah, you guys are neighbors. Yeah.
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 Okay.
Okay,
All right.
guys.
Well, thanks,
Guys.
Ken, for everything.
Bye.
Thanks, Doctor. Appreciate you guys.
Take care. Invite your friends next time.
You bet.
Okay.
Have a good one.
Signing